Welcome to the Deep Dive, your shortcut to being genuinely well-informed. We dig into a stack of sources, pull out the key insights, the surprises, sometimes even the funny bits. Today, we're tackling something that touches almost all of us. Low back pain, it's super common, right? Can be kind of scary, feels like it takes over everything sometimes. But what is it, really? When should you actually worry? And what truly helps? We're going to explore all of how common it is, the real causes, diagnosis, treatments, some new breakthroughs, and how to prevent it.
Yeah, our mission here is to cut through some of the myths, guide you through the latest thinking, and give you actionable stuff based on clinical guidelines, new research, the works. And you'll hear about a big shift, actually, in understanding, moving away from just looking at the spine structure to a more holistic view of pain itself.
Okay, let's dive right in then. When we say low back pain, what are we actually describing? What's the definition?
Simply put, it's discomfort, pain in the area between the bottom of your ribs and your buttock. Could be a dull ache, could be sharp, intense. Sometimes it might spread down into one leg or even both, but the main focus is usually the back. We also talk about how long it lasts. So acute is under 6 weeks. Subacute is like 6 to 12 weeks. And chronic means it's sticking around for over 12 weeks. And here's something important right off the bat. Even persistent chronic low back pain is, very rarely caused by something medically serious.
That's good to hear up front, I bet, for a lot of people. But just how widespread is this? How many people are dealing with it?
Oh, it's huge. Up to 84% of adults will have low back pain at some point. Think about that. Almost everyone you know, basically. It's actually the single biggest cause of disability worldwide. Looking at numbers, in 2020, that was 619 million people affected. And they estimate that'll jump to 843 million by 2050, mostly because of population growth and, aging.
Wow, 843 million. That's a staggering increase. Does it tend to hit certain groups harder, like specific ages or demographics?
It really can affect anyone, any age, even kids and teenagers, which surprises some folks. But yeah, while it's across the board, the highest number of cases tends to peak around age 50 to 55. And it does get more common as people get older, up to about 80. It's also seen a little more often in women.
Okay, so it's incredibly common. Why? Why is the lower back like such a hot spot for pain? What's going on there?
Well, mechanically speaking, your lower back does a lot of the heavy lifting, right? But it usually only has 5 vertebrae down there. It's the link between your spine and your pelvis, and it has to support the weight of your whole upper body. Plus, it moves a lot, handles a lot of stress just through daily life. So all that can lead to, wear and tear and injuries over time. It's just a high-stress area.
Right. And when people think back pain, they often jump to specific things like almost a slipped a disc or I injured it lifting. What are those common structural causes we usually hear about?
You're right, those are definitely on the list. Things like arthritis of the spine. That's basically the slow breakdown of the spinal joints. It's a really normal part of aging, actually. The cartilage wears down, you get inflammation, friction. Then you have back injuries. Can be sudden, a fall, car accident, that kind of thing. But often it's slower, from everyday tasks done maybe a bit awkwardly, like bending wrong to pick something up, carrying heavy laundry, holding a child for ages. It just adds up.
Yeah.
And yeah, herniated or bulging discs, that's when a disc kind of pushes out of place. Now, these are often painless.
Often painless. Okay, that's interesting.
Yeah, but sometimes the disc material can press on or irritate nerves nearby, and that's what causes the pain.
So those are the usual suspects. But you mentioned a shift in thinking. This is where it gets really interesting, right? What about when someone gets an MRI? What does that actually tell us?
This is such a crucial point, and it really messes with what people expect. Get this. Somewhere between 40 and 80% of adults with no back pain at all.
No pain?
Zero pain. They have at least one bulging or herniated disc showing up on their MRI. And for degenerative disc changes, that number hits 93% after age 60. So what does that mean? It means these structural changes are often just normal aging, like wrinkles on the inside, which means MRIs aren't actually that helpful for diagnosing most low back pain. In fact, something like 85 to 90% of cases. They don't have a specific structural cause we can pinpoint. We call it non-specific back pain.
Wow. 85 to 90% nonspecific. So it's not just about a picture of your spine. That's a huge takeaway.
Exactly. And think about the definition of pain itself. It's an unpleasant sensory and emotional experience. Tissue damage isn't always necessary to feel pain, and having tissue damage doesn't automatically mean you'll feel pain. What's even more fascinating is what does predict long-term pain better than an MRI finding. It's often your thoughts and feelings about the pain.
Thoughts and feelings. Like what?
Like believing the pain means serious harm is happening. being afraid to move or do activities, fearing the pain will never go away, depression, even things like job dissatisfaction, and lifestyle habits too, smoking, not being active. Those are stronger predictors of chronic pain than what the scan shows. And that's actually good news, right? Because it means there's a lot you, the individual, can potentially influence to get better.
That is empowering. Definitely changes the narrative. Speaking of surprising things, what about some other factors? People swear the weather makes their back worse. Any truth there?
Absolutely, for some people. Changes in weather, especially barometric pressure and temperature, can worsen back pain, particularly if there's underlying arthritis in the joints. Muscles and joints can react to those shifts. Another thing, sometimes kidney pain gets mistaken for back pain because, anatomically, your kidneys sit towards your back. So
Yeah.
you really need a doctor's exam to tell the difference there.
Good distinction. Okay, let's tackle the big fear factor. When should someone genuinely worry that their low back pain is a sign of something serious? What are the red flags?
Right. It's a valid worry. And again, most LBP isn't serious. But there are clear red flags that need urgent medical attention. Things like severe, constant pain that doesn't get better with rest or even gets worse at night, unexplained weight loss, or having a persistent fever or night sweats. Also, any major or worsening weakness, numbness, or tingling in your legs that needs checking out quickly. And then there are the really critical ones, new problems with bowel or bladder control like incontinence or not being able to urinate, or saddle anesthesia, which is numbness in the groin and buttock area. Those could be signs of Cauda-Equina syndrome, a medical emergency needing immediate action.
Okay, those sound definitely urgent. Any other warning signs people should know?
Yes, a few others. Pain shooting down both legs, what we call bilateral radicular symptoms, a history of osteoporosis, previous spine surgery, or cancer that could spread to bone, especially if it's new pain in someone over 50. Also, significant trauma, obviously, long-term use of steroid medications, having a suppressed immune system, or a history of IV drug use. And finally, persistent back pain in someone under 20 might need a look for possible congenital issues.
Got it. So, assuming none of those red flags are present, how is low back pain usually diagnosed? Is it straight to the MRI machine like many assume?
Generally, no, not as the first step. Often the diagnosis can be made just from talking about your history and doing a physical exam. There are special physical tests for nerve issues, but honestly their accuracy is kind of limited. And here's the key thing about imaging, like X-rays or MRIs. You usually don't need them right away unless those red flags pop up, or if the pain is getting much worse, is really severe, or just isn't getting better after about, say, 12 weeks of trying other treatments. In fact, studies show getting an MRI early on for low back pain actually makes surgery 13 times more likely.
13 times.
Wow. Yeah. And it's also linked to more opioid use, higher costs, worse pain scores, and more time off work. So rushing to image often doesn't help and might even lead down a less helpful path.
That's a really strong point against just defaulting to scans.
Yeah.
Okay, so if scans aren't the first move, what are the recommended approaches? What's the roadmap to managing this and feeling better?
The big picture is that care needs to be centered on you, the patient. It should be holistic, looking at the whole person, equitable, integrated. Shared decision-making with your provider is key. The goal isn't just stopping the pain, it's getting you back to an active, fulfilling life. So for new pain, the recommendation is usually conservative therapy for about 4 to 6 weeks. And the number one thing, stay active. Avoid total bed rest. Gentle movement is good. Try to avoid excessive twisting and bending initially. Most people find their pain improves quite a bit within a month and often resolves within 2 months. So don't wait until you're totally pain-free to start getting back to normal activities. Carefully.
Okay, stay active. What about specific treatments during that first phase? Heat, pills?
Yeah, non-drug approaches first are great. Try things like applying heat, massage, maybe acupuncture or yoga, even spinal manipulation from a qualified practitioner. If you're looking at medication, a short course of an NSAID like ibuprofen or naproxen can be considered, assuming it's safe for you. If that doesn't cut it, sometimes non-benzodiazepine muscle relaxants like cyclobenzaprine might be suggested for a short time. Interestingly, acetaminophen, Tylenol hasn't really shown strong evidence of benefit for low back pain in trials compared to a placebo.
Huh, okay. Good to know about acetaminophen. So what happens if after those 4 to 6 weeks the pain just isn't budging?
If it's not improving, that's usually when a referral to physical therapy or PT comes in. And you'd continue with those non-invasive, non-drug approaches, exercise, maybe multidisciplinary rehab, which involves different types of therapists, acupuncture, CBT, cognitive behavioral therapy. Your doctor might also think about trying a different NSAE or adding a muscle relaxant if you haven't tried one. A good physiotherapist, especially a chartered one, can do a really detailed assessment, create a personalized plan, help you figure out how to return to work or sports safely, and teach you how to minimize the chances of it coming back. The core evidence-based PT tools are usually education, exercise therapy strengthening, stretching, conditioning, and manual therapy, like joint mobilization or manipulation.
That sounds like a solid standard approach.
Yeah.
But you mentioned breakthroughs earlier. That got my attention. What's new and exciting in the world of LBP treatment?
Right. One really significant development is something called cognitive functional therapy, or CFT.
Mm.
It's being talked about as a high-value, low-risk approach. It's basically a personalized program, usually about 7 sessions, delivered by physiotherapists who've had special training in it. It uses what's called a biopsychosocial model. So it looks at the physical factors, sure, but also the psychological stuff, thoughts, fears, emotions, and the social context, like work and activities. CFT is very movement-focused. It's designed to put you back in control. It gives you skills to manage the pain, build your confidence to move again, and helps you gradually get back to activities you might have started avoiding because of fear. It also tackles relevant lifestyle factors. And the data is pretty compelling. The RESTORE trial, a big, high-quality study, showed CFT led to significant reductions in pain and improvements in function, and importantly, those benefits were largely still there 3 years later.
3 years.
So
That's impressive longevity.
it is. It's the first big study showing that kind of long-term impact. It really offers a potential lasting solution, unlike things that just manage symptom short-term, like maybe massage or meds. CFT could have a major impact both for individuals and economically.
That sounds really promising, shifting the focus to empowerment and long-term skills.
Yeah.
You also mentioned acupuncture earlier as an option. How effective is that generally seen for chronic pain?
Yeah, the evidence suggests acupuncture can be effective for chronic low back pain. Some studies show pain reduction lasting up to a year. There was a really interesting case study, a patient who'd had chronic LBP for 6 years, tried lots of physio, didn't get much relief. Then, just 4 acupuncture sessions over 4 weeks, his pain dropped from an 8 out of 10 down to a 2 out of 10. His mobility improved massively. He got back to gardening, even helped a friend with home renovations. It often seems to work best when it's used alongside conventional therapy as part of a broader plan.
Okay, now, just as vital as knowing what helps is knowing what doesn't, or what to be careful with. What treatments fall into the caution or avoid category?
Super important point. Medications can help symptoms, definitely, but they shouldn't necessarily be the first thing you reach for. We already mentioned acetaminophen. The evidence for LBP just isn't strong. Then there are opioids. Apart from maybe tramadol as a last resort, they generally aren't better than non-opioids for helping function in chronic pain, and they come with serious long-term risks, dependence, overdoses. The World Health Organization advises against routine opioid use for chronic LBP. Benzodiazepines like Valium or Xanax are also not recommended. No proven benefit for back pain specifically.
What about other common prescriptions, like nerve pain meds or steroids?
Right. Anticonvulsants like gabapentin or pregabalin, often used for nerve pain studies, show they're no better than placebo for general LBP and sciatica, but they do cause more side effects. Systemic corticosteroids like prednisone pills, they don't really improve pain in either acute or chronic LBP, maybe a tiny temporary improvement in disability for acute cases, but that's about it. And then there's a whole list of physical therapies or devices that just don't have strong, consistent evidence supporting their routine use. Things like lumbar braces or belts, mechanical traction, cupping, laser therapy, TNS machines, ultrasound therapy. The evidence just isn't there for routine recommendation.
That's quite a list of things that might not be worth the time or money. What about more invasive stuff, injections, procedures?
Yeah, for many invasive procedures, the evidence is also pretty limited or uncertain for significant lasting benefit. This includes things like radiofrequency ablation, epidural steroid injections, facet joint injections, SI joint injections, spinal cord stimulators, even orthobiologics like PRP or stem cell injections. The research just doesn't consistently show big long-term improvements in pain or function for most people with non-specific LBP. The focus really remains on comprehensive, conservative care first.
Okay, so we've covered a lot: what it is, causes, diagnosis, treatment, what to avoid. Let's talk prevention. Because once you've had a bad bout of back pain, you really don't want it again. Can you prevent it?
That's the million-dollar question, isn't it? Unfortunately, recurrence is pretty common. Estimates are around 60 to 86% of people have another episode within a year.
Oof, that's high.
It is. But, and this is but exercise programs and education have been shown to lower that risk. So long-term lifestyle changes really are key.
All right, so what does that mean practically? For someone listening who wants to avoid future episodes or just manage things better long-term, what are the takeaways?
I think the biggest message is you are in control of whether or not you get better. It's about taking an active role. Key strategies. Number 1, be physically active. The guidelines suggest at least 150 minutes a week of moderate activity, brisk walking, swimming, cycling, or aiming for around 10,000 steps a day. Specific exercises like yoga and Pilates can definitely help too. The core idea is hurt does not equal harm. It's usually okay to move, even if it's a bit uncomfortable. Often, moving less makes it worse. Don't be afraid to bend and lift carefully. Your back is actually very strong.
That's such a powerful mindset shift. Hurt doesn't mean harm. What else helps build that long-term resilience?
Optimizing mental well-being is huge. Dealing with low mood, stress, anxiety. We know negative feelings can actually turn up the volume on pain. So things like CBT, mindfulness, getting psychological support if needed, that's really important. Other big ones. Maintaining a healthy body weight reduces stress on the spine. Not smoking tobacco smoking messes with healing and increases inflammation. Getting good quality sleep, staying engaged socially and at work, and making ergonomic adjustments where you work or spend a lot of time. It's really a whole person approach.
Makes sense. It's all connected. And what if, despite your best efforts, the pain does come back?
If it recurs, getting in to see a physical therapist quickly usually leads to better results than just waiting it out. Sometimes it might only take 1 or 2 visits to get assessed, get some advice, regain confidence, and get back on track. Early intervention is often helpful.
Okay, so let's wrap up this deep dive. Low back pain, incredibly common, affects almost everyone eventually, but most of the time, it's not actually serious. What we've learned is that understanding the whole picture, the physical side, yes, but also the emotional, the social factors that interplay is absolutely key to managing it well and, getting on with life.
Exactly. And maybe instead of always asking, what's wrong with my back structure? A more empowering question for long-term well-being is, what can I learn from this pain experience? And how can I take charge to live well, even with it?
That's a fantastic thought to end on. Really shifts the perspective from damage to empowerment. We hope this deep dive has given you, our listener, a clearer picture and maybe some new tools to think about low back pain, whether it's something you deal with now or might in the future. Thanks for joining us.